I'll be presenting on
Recording in progress.
the topic classification and management of enterocutaneous fistula. So the introduction / epidemiology. Fistula is defined as an abnormal communication between two epithelialized surfaces. While an enterocutaneous fistula is an abnormal communication between intestinal tract and the skin, leading to the leakage of intestinal content through the skin. The ileum is the most common site of origin of enterocutaneous fistula. Epidemiologically, ECFs are relatively rare, with an incidence of about 1 to 2% of all surgical patients. They can occur at any age, but they are more commonly seen in adults, particularly in middle-aged individuals. The classification of enterocutaneous fistulas can be based on several factors. We have classification by anatomy, by physiology, by location. So based on classification by anatomy, we have the internal fistula and the external fistula. The internal fistula are named after the structure it communicates with, like the gastrocolic fistula, the jejunal-ileal, and the aortoenteric fistula. The gastrocolic, like when the gastric, and the stomach and the colon are being communicated abnormally, so it's called like a gastrocolic fistula. Well, external fistulas are like examples are the gastric, duodenal, jejunal, ileal, or fecal fistula. So by physiology, we have the high output fistulas, and this have outputs like the secretions coming out from the fistula. Their outputs are greater than 500 ml per day. Well, the low output fistulas, the outputs are less than 500 ml per day. Then by location, we have the proximal and the distal. The proximal fistula is near the stomach, while the distal fistula is near the colon. So we have the etiology. Enterocutaneous fistulas are commonly iatrogenic, 75 to 85%, that is, and they are the most common type of small bowel fistulas. Now we have Webster and Carey, who proposed 5 general mechanisms for internal fistula formation. So they proposed that intestinal fistula can be formed by mechanism of congenital, could be through trauma, infection, it could be through perforation or injury with abscess, or it could be through inflammation, radiation, or tumor. So based on the congenital, when there's a complete failure of the vitalointestinal duct to obliterate, it results in enterocutaneous fistula to the umbilicus. So there will be an abnormal communication with the skin, the umbilicus, and the enteric gut. Then it will be based on trauma. We have enteroatmospheric fistulas, which occur after damage control laparotomy. Then major penetrating trauma to the abdomen may lead to the formation of a fistula, but this is rare. Infection. An abscess or an invasive intestinal infection like amoebiasis, tuberculosis, coccidioidomycosis, etc., cause an enterocutaneous fistula. Actinomyces is a common cause of enterocutaneous fistula after appendicectomy, because mostly appendicectomy is like one of the major surgeries that leads to an enterocutaneous fistula. So the fourth mechanism is by perforation or injury with abscess and operative conditions. So 60% to 90% of enterocutaneous fistulas are caused by operative complications. In addition, enterocutaneous fistulas are caused by leakage from an intestinal anastomosis or enterotomy closure. The fifth mechanism is inflammation, radiation, or tumor. Spontaneous external fistula can develop in Crohn's disease, but most occur only after a surgery. It causes diseased intestine to adhere to the abdominal wall. Fistulas that arise secondary to radiation injury rarely close spontaneously. That's because, normally we expect an enterocutaneous fistula to spontaneously close, but an enterocutaneous fistula that was caused by radiation injury, they rarely close spontaneously. So that's when they will need maybe a surgical repair. Now we have the pathogenesis of enterocutaneous fistula. The pathogenesis of enterocutaneous fistula involves the combination of factors that led to the formation of the fistula. We have the primary factors and the secondary factors. The primary factors, they lead to the secondary factors. The primary factors include injury or damage to the intestines or surrounding tissue, infection or inflammation, ischemia or impaired blood flow, for the presence of foreign bodies. All the secondary factors include tissue necrosis and sloughing, enzymatic digestion of tissue by intestinal contents, granulation tissue formation, and the epithelialization of the fistula tract. Mechanism. Direct injury could be caused by trauma, surgery, or radiation damage to the intestinal tissue, while an indirect injury could result from an infection, inflammation, or ischemia compromising the intestinal integrity. Then a formation of adhesion formation. Fibrin deposits and adhesions form between the intestine and the skin, while the fistula tract establishment. Granulation tissue and epithelialization stabilize the connection. So what this basically saying is that like the injury could occur first to the, or damage to the intestines could occur first, and that will lead to like the tissue necrosis and sloughing. Then infection and inflammation here can bring about this granulation tissue formation. And also the secretions from the intestine, since there's an abnormal connection between the enteric gut and the skin, the secretions from the intestine leaking outside could damage the tissue of the skin also. I'm through my part. Thank you. My colleague will continue with the management of enterocutaneous fistula. Stop sharing. Stop sharing. I'm trying to.
Recording in progress.
Presents. My name is Zubaida Lawal Gwarenyo, and I'm going to present the management, history, treatment, and conclusion. The management of enterocutaneous fistula can either be elective or emergency due to the, it depends on how a patient presents themselves in the hospital. If it's It sometimes it requires conservative therapy or surgical therapy. But for history, how they will present is that it can be general, non-specific constitutional symptoms. They can present with weakness, fever, chills, poor appetite, and protein and caloric malnutrition. Other specific symptoms that can be seen in enterocutenous fistula, like it's a must to be seen in these patients. We have feculent villous wound discharge from the drain site and the main abdominal wound, diarrhea, gastrointestinal bleeding. Organ-specific symptoms are usually related to the organs involved in the fistula. Examples are organ-specific clinical manifestations are recurrent polymicrobial urinary tract infection, pneumaturia, fecaluria in a colovesical fistula, post-operative abdominal pain, tenderness, and distension. Other symptoms that can be seen in these patients are tachycardia and pyrexia. As may signs of localized or diffuse peritonitis, including guiding rigidity and rebound tenderness.
Recording in progress.
This is important because of sepsis, which can lead to leukocytosis, serum sodium, potassium, and chloride level tests, which is to test for electrolyte abnormalities, which can result from fluid and electrolyte loss, complete blood counts, total protein, serum albumin, and globulin tests. These can demonstrate the presence of malnutrition and associated anemia, hypoalbuminemia. Serum transferrin test and serum C reactive protein test. Low levels of this transferrin are predictor of poor healing, which is one of the factors of enterocutenous fistula.
We can't see your slide.
Sorry, sir. Sir, can you see it now?
Yes, go ahead.
Other investigations, we have fistulography, which during this test, a water-soluble contrast agent is injected into the fistulous tract. It is conventionally performed 7 to 10 days after the presentation of the extracutaneous fistula and provides the following information: length of the tract, extent of the bowel wall, disruption, location of the fistula, presence of a distal obstruction, and then there's water-soluble contrast enema, computed tomography, ultrasonography, and MRI. Some complications that can be seen in extracutaneous fistula patients are sepsis, and malnutrition. Sepsis severity depends on the extracellular fluid form with higher degrees in indirect tract, and this is because in indirect this in malnutrition, a significant prognostic factor for spontaneous fistula closure, is a significant risk factor. Nearly 70% of extracellular extracutaneous fistula patients may have malnutrition, and sepsis, malnutrition, and electrolyte imbalance are the main causes of death. Intestinal failure is rare but can result in significant morbidity and mortality. And the reason why I said the sepsis severity depends on the extracutaneous fistula form with higher degree in indirect tracts is because it often involves systematic infections that can rapidly spread through the bloodstreams, can lead to widespread inflammation and multi-organ failure. For treatments, for extracutaneous fistula patient, like I said, is how the patient presents in the hospital. It can be elective or emergency, depending on how the patient appears to be when they are in the hospital. If it's elective, conventional therapy for these patients is initiated in its initial phase, while if it's emergency, then they need to go through surgery therapy. Immediate surgery is contraindicated on these patients, as most of them these patients, surgical intervention is necessary because of adverse factors, including lateral duodenal fistula, ileal fistula, high output fistula, fistula associated with diseased bowel. So surgical intervention is risky in patients with sepsis and poor general conditions. First of all, the first step to this treatment is the resuscitation and stabilization of the patient by intravenous fluid. Back to the initial treatment for the elective patients, which is conservative therapy. So conservative treatment should usually be administered for a period ranging from a week to a few months. The principles of non-surgical therapy for enterocutenous fistula patients include rehydration, administration of antibiotics, correction of anemia, electrolyte repletion, drainage of obvious abscess, nutritional support, control of fistula drainage, skin protection. With the above-mentioned supportive therapy, spontaneous closure occurs in almost 70% of all these patients. In a study by Riba et al., 91% of small bowel fistulas that closed spontaneously did so within 1 month after sepsis was cured. The remaining fistulas that closed spontaneously did so by the end of 3 months after sepsis cure, with the rest of the lesions requiring surgical closure. Number one, according to the supportive therapy, rehydration, electrolyte repletion, and nutritional support. In patients with enterocutaneous fistula, common fluid and electrolyte problems include dehydration, hyponatremia, hypokalemia, and metabolic acidosis. Parenteral nutrition is more common in proximal small bowel enterocutaneous fistulas, particularly those with high output fistulas. Enteral nutrition is preferred for distal enterocutaneous fistulas. A combination of parenteral and enteral nutrition can protect mucosal barrier integrity and gut function. Well, total parenteral nutrition is recommended for suspected gastric, duodenal, or small bowel fistulas, but discontinuing oral intake is recommended for high fistula outputs. Home parenteral nutrition is crucial for enterocutaneous fistula patients, providing greater protein provision, frequent NPO status, and aiming for future surgeries. And then the second one is skin management. A fistula assessment guide for managing enteric fluids based on factors like fistula origin, effluent nature, skin condition, and opening locations. High output fistulas prefer pouch systems, a way of managing the fistulas, while low output fistulas prefer skin barriers. Skin irritation levels guide the application of skin protecting agents and pouch systems. High fistula output requires a pouch for collecting effluents, with one-piece pouches being more suitable for irregular body contours. Transparent pouches are preferred for visualization and durability. Wound manager bags are recommended for easy wound care. So pharmacological agents used in the management of fistulas: number one, somatostatin analog octreotide. 2, proton pump inhibitors such as omeprazole and H2 receptor antagonists. And for the surgical therapy, for those that need emergency treatments, that it was indicated that they needed surgery, patients who are in enterocutaneous fistula with adverse factors may require earlier surgical interventions. These adverse factors include lateral duodenal or ligaments of thread fistula, ileal fistulas, high output fistulas, fistula associated with disease bowel, distal obstruction, or eversion of mucosa. So these are the factors that will initiate emergency surgical procedures. And monitoring of an enterocutaneous patient, daily blood tests, it also needs to be monitored, such as their electrolytes and magnesium. Monitoring fistula outputs and their urine outputs is also important. And to prevent the enterocutaneous fistula, meticulous surgery to avoid iatrogenic injury to the guts, avoid excessive adhesiolysis, optimize patient condition. Serosal tears should be examined carefully and repaired if required. In conclusion, enterocutaneous fistulas are complex clinical challenges requiring a multifaceted management approach. Key factors include understanding their causes, timely diagnosis, and comprehensive assessment. Treatment often involves conservative management, nutritional support, and potential surgical interventions. Advances in surgical techniques and wound care have improved patient outcomes. A multidisciplinary approach is essential for optimizing healing and quality of life. Thank you very much.
Your references.
Sir, it's my slide that I was supposed to use. It has reference.
Highlight the references. Let's see.
Yeah.
You should have the references highlighted. We need to examine them. Can you highlight the references?
Okay. I'm coming. Let me send it in.
Okay, before highlighting the references, we'll continue the discussion. When you get the references, just display them on the page and share.
Okay, sir.
Yes, sir.
So, well done. You did well. You tried for the presentation. This is the next session now will be the discussion session. Questions, comments, and contributions. I can see Dr. Bima, you are with us.
Yes, sir. Good evening, sir.
Okay, please, do you have any comments to make? Questions?
Yeah, I think it was a very good presentation. I just have a few contributions.
Okay,
I'm not sure I have questions.
go ahead, please.
Okay. So for your classification, I think it was rather incomplete. I don't know. For your anatomic classification, you talked about internal, external, you talked about proximal, distal. So it's also important to know the involved circumference of the bowel, if it's an end fistula or if it's a lateral, if it's a circumference of the wall or if it's the whole circumference of the bowel that is the fistulous tract, as this helps to guide one in decision making. Then we also have what we call, based on the nature of the tract, you can say it's a simple tract, which is usually single, just a single fistulous tract with no associated abscess. or collection, or a complex tract that is multiple or with coexisting, either if it's a multiple tract or if it's coexisting with an abscess cavity. Then based on chronologic classification, you can say if it's early or late. Early cases are usually when it's less than 5 days post-op, which is what we see most of the time. Then late is when it's above 5 days post-operatively. Then I think it's important to outline the problems when it comes to enterocutaneous fistula, so you're able to manage it as it should be managed. The patient has, I think you talked about dehydration. Patient can come in shock. Electrolyte derangement, you talked about it, but I didn't hear anything about malnutrition. These patients are, most times, are usually scared of eating because of the effluent. So they usually tend not to eat. So malnutrition is also a problem, coupled with the associated sepsis and the rest. So the patient can also be anemic from also the malnutrition and the ongoing sepsis. And that can all culminate into immunosuppression. Then the fact that there is feces coming out from an external opening on their body, that is so worrisome. So psychological trauma too, they can have psychological disturbance. So part of the management is to get psychological help for the patient. Then they talked about it, they can present as emergency or not, right? Okay, then I don't know if you talked about anthropometric measurement of the patient, because right from when the patient comes to admission, you need to measure the weight, the height, and calculate the body mass index, because you use that as a baseline to mark or to gauge the patient's response to your treatment, especially if it's conservative. Then in your investigations, you always talked about EUCR, full blood count. You need to also measure serum proteins, because of course malnutrition is a problem with patients with enterocutaneous fistula. So serum proteins, albumin, transferrin, C-reactive proteins, retinoid binding, just markers of malnutrition in general. Okay.
Okay, ma, thank you.
So okay, that's all, sir, that I have for now.
Okay, that is very,
Hello?
those are excellent comments and contributions from Dr. B. Of course, the topic being classification, you have to go in depth in talking about other possible ways of classifying enterocutaneous fistula, which Dr. Bima just outlined. These are very important and they have bearing in the management. Of course, when you see the way she classified them, they are usually clinical. They are clinically oriented classification, because when you see a fistula that is early, less than 5 days, usually this is a post-operative. Usually, they are commonly associated with operations that failed, that became complicated. They come up with fistula within 5 days, okay? Maybe due to some error in the procedure, complications, or breakage of sutures or something. They usually present early, okay? Less than 5 days, you know, this usually just follows a post-operative course, okay? Or late, that occur later after 5 days, okay? May not be directly related to the immediate procedure that was performed. So that is very good. And other classification, if you take notes, they have bearing also in the management. A simple fistula or a complex fistula. Complex fistula are difficult to treat because they will have multiple tracts, or you have to drain an abscess it is linked to an abscess cavity. So you have to drain that or else it won't heal. Now, she mentioned something which is very important also in the classification, whether it's an end fistula or a lateral fistula. Of course, if it is an end fistula, the stoma is greater than or equal to 2/3 of the circumference of the bowel involved. Usually, they don't heal spontaneously when they are end fistula. You must intervene surgically because the circumference is just like a complete circumference leaking to the skin. So that has to be intervened. And mark you, in the examination, you have to do a digital rectal examination. It's very important. Any examination of a patient with fistula without digital rectal examination is incomplete, because it tells you whether it's an end fistula or just a lateral one. Because if the rectum is empty, it means it is an end fistula. Everything is going out through the stoma. Nothing is coming to the distal segment of the bowel. So that is very important. And also, you ask the patient whether he's passing stool or not. That is also very important. If patient is not passing stool, it means it's an end fistula. Okay, everything is coming out through the stoma. So this point she raised about going in depth in the various classification is very important. Of course, the first classification you gave, internal fistula, is not an enterocutaneous fistula. That is just classification of fistulas generally. When you say enterocutaneous, is from the intestine to the skin. When you have stomach connecting to a small bowel, that is not enterocutaneous. That is just a form of classifying an internal fistula. Okay, rather that is a classification of fistula as internal or external. It is external enterocutaneous. You understand? So any other comments or questions from the members, your group members, the class members, before I make my own comments and questions? If you have a question, you can unmute yourself, introduce yourself and ask. You can go ahead. Any question? Yes, any question? Okay, I can't see the reference. You've not seen your reference material. You've not shared your reference.
Sorry, sir, I have a question.
Okay, go ahead.
Based on the records I found, it says that the enterocutaneous fistulas are rare and seen like 1 to 2% of all surgical patients. So I just wanted to ask if that is really true. Is that how rare it is?
That's why we are asking for your references to see where you got all your materials from. It is not rare, it's a common complication. It's a common problem you see, because the operations that are associated with fistula are amongst the common surgical emergencies, like acute appendectomy. Okay, surgery for acute appendicitis, appendectomy. Okay, it's a common procedure. And second, you can also emergency procedures. They are also associated and fistula. So that is not completely true. Saying that enterocutenous is rare is not. Yes, any other question?
Sir, I also have a question. It's
It's
regarding
regarding
while
while
I
I
was
was
researching for
researching for
the
the
presentation,
presentation.
there were
There
some
were some
pages
pages
where the
where the
treatment was
treatment was
conservative
conservative
treatment for
treatment for
elective
elective
and
and
for
for
surgery with
surgery with
emergency. And
emergency.
then
And
for
then for
some they
some
were
they were
showing me
showing me
SNAP,
SNAP,
No.
SNAP, which
SNAP, which
was
was
stabilization,
stabilization,
sepsis
sepsis
control,
control,
skincare,
skincare,
nutrition.
nutrition.
And I was
And I was
now
now
a bit
a bit
confused
confused
where
where
the
the
conservative
conservative
treatment will
treatment will
fall
fall
under,
under,
because the
because the
conservative
conservative
treatment have
treatment
all
have
the
all the
We can't
rehydration,
hear what you are saying.
all
You have
them.
to switch off. We can't hear you. You are just there are echoes.
Sir,
You have multiple speakers there. So we can't hear what you have to stop one. The volume of one. You have to come again. You have echo in
hello,
You have
sir, can you hear me now?
can mute one of your.
It's now.
Okay, you can go ahead.
So the question was, while I was researching on the topic, I came across some treatments for the enterocutenous fistula. On some pages, they showed me only conservative, while some books I saw conservative treatments and for emergencies, surgical treatments. And for some, they showed me SNAP, which was stabilization, sepsis control, skincare, nutrition, anatomy identification, plan to deal with the fistula. And I was a bit confused on where to put it, because the stabilization and sepsis control, they are all under the conservative treatment, which was for the symptomatic, which was for the symptomatic supportive therapy, because under the stabilization and sepsis control, it can be found in the rehydration, administration of antibiotics, correction of anemia, electrolyte repletion, nutritional support, and the rest.
So you see, fistula management in phases actually. Okay, the management of you still have echo. Have you muted your?
So I can hear now.
Yes. The management of enterocutenous fistula usually is in phases. Okay, when you are presenting a topic, you have to choose a particular pattern from one of the reference materials that are acceptable. You understand there are standard textbooks, or if you are using a journal, there are standard acceptable journals or reference material or reference textbooks that have standard method of managing intracutaneous fistula. So when you see multiple methods, you just choose one and stick to it and present. For example, if you are using the SNAP, well, it's acceptable in some of the reference textbook, or if you are using the phases of management. Commonly, we use phases of managing intracutaneous fistula from phase 1 to phase 4 or 5. There are about 5 phases of managing intracutaneous fistula. So if you follow that pattern, there will be no confusion. So did you come across the phases while you are reading? Did you come across the phases?
Yes, I think I did.
Okay, you should have just used the phases and you won't have any confusion. For example, you have phase 1. Okay, phase 1. Okay, let's see if I can write with this. So phase 1 is called recognition and stabilization. That is what you saw. All that your resuscitative measures you mentioned, they are all under recognition and stabilization. That is the first phase. So if you are using the phases, you will not get confused, because from phase 1, once you see a patient with enterocutaneous fistula, you know your first role is 1, to stabilize the patient. 1, you have to recognize that yes, this patient has a fistula, and what are the problems? You identify 1, that there is a fistula. 2, there are some problems. If you remember, Dr. Bima was emphasizing on the problems of enterocutaneous fistula. So you have to identify that yes, there are some certain problems which requires stabilization. And these problems are fluid and electrolyte derangements. Okay, so you have to correct dehydration. You have to correct this electrolytemia. Now, 1, at presentation, patient will have abnormal discharge of feculent material from a post-operative wound or through the anterior abdominal wall. Sometimes you have to give them activated charcoal or some colored or dyed fluid to take, and you see that fluid discharging through that opening. Okay, you confirming that yes, this is a fistula. You recognize all the problems and start addressing them. That is phase 1. Then phase 2 will now be definition of anatomy. Okay. After you have recognized that yes, a patient has enterocutaneous fistula, the next phase is to define the anatomy. Okay. That yes, this patient has a fistula, then what type of fistula the patient has. That is where you now go into investigating the fistula, where you do a fistulogram. Okay. You inject a dye or a contrast, and you now take an x-ray. The x-ray will show you the pathway or the tract of the fistula. That is a fistulogram. Or you do a CT scan that will show you the various tracts, and if there is associated abscess cavity, it will show you. Is that clear? So that is definition of anatomy. When you were presenting all the investigations, you did not mention what you are expected to see or look for from the investigation. You are just listing investigation. You are supposed to mention what you are expected to see in the investigation. So the second phase now is definition of anatomy. Okay. So that is how you go about it. Then the next phase is phase 3. Okay, now your phase 3, you have to continue. You do nutritional. You remember there is malnutrition in the problem, so you have to commence your nutritional rehabilitation and continuous resuscitation, because resuscitation is a continuous process. Then stage 4 is decision making. And in your decision making, you want to decide, is this fistula going to close spontaneously, or do you need to intervene with surgery? So that is when you now look for those factors that will prevent fistula from healing. If the patient have those factors that will prevent fistula from healing, you have to make a decision. You have to operate on the patient, because it's not going to heal spontaneously. So it is at the phase of decision making. You decide, am I managing this fistula conservatively, or am I going to intervene surgically? And what determines this decision making is the presence or absence of friends, the mnemonic. You told us about friends. It's a mnemonic. F is foreign body, R is fistula resulting from radiation, I inflammatory, chronic granulomatous inflammation or infections. Okay, E, N fistula resulting from neoplasm. Okay, and D, fistula with distal obstruction, and S is fistula with short tract. Any of these will require surgical intervention, so you have to intervene. Okay, then phase 5, of course, is the definitive treatment. If you are giving surgical treatment, there are various surgical interventions depending on what fistula you are dealing with. If the fistula is a complex fistula with abscess cavity, of course, amongst the early surgical intervention you do is to do incision and drainage of that abscess cavity. Another surgical intervention is resection and anastomosis of the segment of involved bowel. Okay, When fistula fails to close spontaneously, you have to resect that segment and anastomose. Don't just go and do a because usually the pathology preventing that fistula may be present, affecting that segment you are trying to close by simple closure. Okay, so resection and anastomosis is also another surgical intervention, or you can even divert if you have a very complex fistula and it's difficult or failing to heal. You can control and divert the fistula, getting a control fistula so that the distal part will heal. Maybe you have multiple openings. You can just do a colostomy or an ileostomy. If you have multiple opening or a difficult fistula in the perineum or rectum, you have to divert, okay, or do an ileostomy. Now, another aspect you need to talk about is the care of the stoma. That is very important. You need to talk about care of the stoma, but because of shortage of time, lack of time, we won't go into details of the discussion of the enterocutaneous fistula, but I'm going to share you a material that you read and you will have more extensive knowledge about enterocutaneous fistula, because enterocutaneous fistula is one of the most important topics in general surgery because of several reasons. But over time, we'll come to discuss more and more about enterocutaneous fistula. We just stop at the basics here, but there are more advanced information over time, maybe in your subsequent postings in surgery. We'll go in detail and discuss in depth about enterocutaneous fistula. But by and large, you did very well. Of course, your slides were not too bulky, and you tried in the presentation. So if there are further questions, you can ask, but if you don't have any other question, you will just stop the presentation here. But if you have any further question, you can go ahead and ask. Okay, I believe there are no questions.
Yes, sir. Thank you, sir.
Clarification? Okay, thank you, everyone. Who are those presenting tomorrow? Who is the group rep?
Yes, I'm here. Yes, I'm here.
Who are those presenting?
Ene and Uju. Ene and Uju.
Are they here?
Yes, sir.
Are they
Good
here?
evening. Yes, sir. Good evening.
Yes, sir.
What is your topic?
Pathogenesis and management of peritonitis.
Okay, that is very good. So, everyone all the group members should read the topic, okay, so that you can have questions. Okay, you should read around peritonitis. You can use Baja, Bailey and Love, and other surgical reference books. So at 8:30, we will continue with the meeting. So good night, everyone.
All right, sir. Thank you.